Welcome to the Sonocyte Behind the Scan webinar called Erector Spinae Blocks, ESP for Spine Surgery. My name is Laura Jacob and I will help to moderate today's webinar. Before we begin, please be advised all attendees are muted. You may type your questions into the Q&A box at the toolbar located at the bottom or side of your screen at any time, and we will conduct a Q&A session at the end of the presentation. This webinar will be recorded and archived for future reference. I'm delighted to introduce our presenter today, Dr. Teresa Bowling. Dr. Bowling is the Director of Anesthesia at the Connecticut Orthopedic Institute and Ayer Spine Institute. She is also the co-director of the Regional Anesthesia and Acute Pain Management Fellowship at St. Vincent's Medical Center. Teresa Bowling is a recognized leader in regional anesthesia training, acute pain management program development, and enhanced recovery after surgery, ERASC, program implementation. From 2008 to 2015, she developed and led the regional anesthesia program at the Stamford Hospital, which was awarded a Center of Excellence designation in 2010. In 2012, she founded the Stamford School of Regional Anesthesia, SSRA. And in 2017, Dr. Bowling joined Integrated Anesthesia Associates, where she is the Director of Regional Anesthesia, and joined the faculty for Quinnipiac University Frank H. Netter School of Medicine as an assistant professor. She is a board member of the Connecticut Quality Surgical Collaboration, where she serves on the ERASC Task Force Committee for Connecticut. And with that, Dr. Bowling, I will turn it over to you.
Thanks so much, Laura. Welcome to the webinar talking about erector spinae blocks for spine surgery, something I'm really passionate about. I really didn't know much about erector spinae blocks prior to the summer of 2020 when we introduced it to our practice for spine surgery. And since then, I've had a tremendous amount of experience with the block, and I've really seen the dramatic effect it's had on our patients from pre-block spinal fusion to post-block spinal fusion. So I hope I can share my enthusiasm about this block with you, teach you about the anatomy, the technique, share some exciting data we've published, and entertain some questions at the end of the webinar. And certainly feel free to contact me at any time via my email address, which Laura will share with you. Going forward, I love answering questions, and if I can help anybody get their program off the ground, I'm happy to share the success we've had at St. Vincent's. So my perspective is unique in some respects because of access to a lot of different practice cultures. I'm a partner at Integrated Anesthesia Associates, which is the largest physician-owned private practice in the state of Connecticut. We service over 34 practice locations that include private community hospitals, academic hospitals. We have a regional anesthesia fellowship at St. Vincent's Medical Center. And we also have ASCs where we do outpatient joints and spines where we do nerve blocks for all of our patients. We're also a teaching hospital for Quinnipiac where we have medical students, and we also have student CRNAs from Yale and from Quinnipiac. So we have a private community hospital at St. Vincent's Medical Center with a real academic flair, providing a unique culture. Hartford Hospital purchased Midstate Medical Center, where they created the first Connecticut Orthopedic Institute, and that is in Meriden, Connecticut, in the center part of the state. The collaborations between the surgeons in the hospital was really unique in the state of Connecticut, and it was really created a tremendous culture of patient care and quality outcomes. The orthopedic center there became successful very quickly. And subsequently, when the Hartford Healthcare bought St. Vincent's in 2019, they decided to open up a second Connecticut Orthopedic Institute, otherwise known as COI, at St. Vincent's. So we're known as COI South and COI North. Both facilities are Joint Commission certified for advanced total hip and total knee. And I'm excited to share that our sister hospital in Meriden is also certified in spine, which is unique to the state of Connecticut. We are currently undergoing review and preparation for Joint Commission certification for spine, really, putting our quality of care, specifically with regional anesthesia, high on the charts and the new benchmark. Between the two institutions, we do about 3,000 spine cases a year, providing a large pool of data that's created us the opportunity to publish and really look at outcomes and change our methods as needed to really provide superior care. In 2020, I was tasked with creating an enhanced recovery after surgery protocol at St. Vincent's. So we reviewed the literature, the team got together, and we decided we were going to introduce erector spinae blocks for spine. We're going to talk now a little bit about erector spinae blocks, how they work, and the anatomy and indications and contraindications. It's a relatively newer interfascial nerve block, first introduced in 2016 to treat neuropathic pain related to metastatic disease to ribs. Shortly thereafter, got adopted for chest wall surgery, for abdominal surgery, but there wasn't a whole lot of literature related to spine in 2019. We did know it could be used for a wide variety of procedures. However, there was a positive literature related to its use for laminectomies and spinal fusions. The specific mechanism of action is still controversial. However, there are some new hypotheses I'll share with you briefly. Like any other nerve block, you have to understand the gross anatomy, the neuroanatomy, the sonoanatomy, and technique. All those four components are critical to have a positive outcome and reliable and predictable successful blocks. If you look at the posterior wall of a patient, the paraspinous muscles are divided into superficial and deep muscles. The muscles course bilaterally from the base of the skull to the sacral region. And landmarks to remember as you're trying to identify anatomy so that you place the erector spinae block at the correct level where the surgical stimulation will be is the rhomboid muscle typically terminates at the 5th thoracic vertebrae, and the distal edge of the scapula terminates at the 7th thoracic vertebrae. Needle placement is always in the paraspinal fascial plane between the erector spinae muscle and the transverse process. You can achieve a multi-dermatomal somatosensory block due to cranial and caudal spread of local anesthetic, conceptually the same as an epidural. Analgesia is achieved to the incision site, the bony structures, and that's why it's so effective for spine surgery, and the surrounding tissues. So when you introduce these blocks for spine surgery, there's no need for the surgeons to use local anesthetic in the subacute tissue or around the incision site. It also provides the added benefit of visceral analgesia. This is a cross-section of the spine in the thoracic area showing the 3 muscle layers from superficial to deep. And the needle insertion site is again at the distal edge of the transverse process. Now we know there's consistent involvement of the dorsal rami across the entire course of the spine. However, there's variable involvement of the ventral rami. It is more likely blocked in the thoracic region. It appears that the thoracolumbar fascia is likely plays a role, but in more recent cadaver studies that I'll show you in a bit, it's unlikely that there's paravertebral spread, which we were thinking might be a mechanism until recently. Indications for this block are widespread. We do use it at our institution for breast surgery. Our cardiothoracic team uses it for their thoracic cases, large abdominal surgery, rib fractures for pain related to trauma. It is documented for hip surgery. I have no experience with that. We have a different protocol for our hips, and of course, spine. Contraindications are relatively few, like any other regional anesthesia, patient refusal, infection at the site of the injection site. Anticoagulation is a relative contraindication, so you really have to use your best judgment and use a risk-benefit profile. If you don't already have the ASRA app on your smartphone, I highly recommend it for a reference when you're deciding about whether to do regional anesthesia and patients on anticoagulation. Complications are also relatively few. In 2019, in the Journal of Clinical Anesthesia, there was a review of 85 publications from 21 journals. And the pooled review yielded 242 reported cases between 2016 and 2018. Infection, bleeding, epidural hematoma, pneumothorax, epidural spread, and failed block were all cited, although incredibly rare. Local anesthetic toxicity is certainly a concern with any kind of plain block because of the large volume of local anesthetic being used. So always be cognizant of the patient's weight and the dose of local anesthetic you're using when you're doing this block. Now we're going to talk about technique. This block can be done in the sitting, prone, or lateral positions. If you're doing a lumbar spine ESP, it's really critical to use a curvilinear transducer. And one of the examples or clinical pearls from this is my partner up at Midstate started doing these blocks after we introduced it at St. Vincent's and had such great success. And she's excellent at regional anesthesia, and she was really struggling, which I found surprising. So we kind of talked around what was going on, and they did not have a curvilinear transducer there. So they got one, and she immediately called me and said it was a game changer. So that is a really important clinical pearl if you're doing this in the lumbar region, that you should definitely start with a curvilinear probe if it's available. As far as the other parts of the spine in the thoracic area, it really just depends on the patient's anatomy. I often start with a linear, but I don't hesitate to change to a curvilinear if I'm having trouble visualizing the structures. And one of the key components of successful regional anesthesia is being able to clearly see the anatomy so that you can put the needle in the appropriate target. We use a single shot technique for these procedures for spine, obviously putting a catheter in the erector spinae space in the spinal area where the surgeons are operating would be technically impossible and would be in the way. And we do have access to long-acting local anesthetic, which means that we can get a longer duration of block without placing an indwelling catheter. Our practice is to place these blocks in the operating room after the patient goes to sleep, whether they're in the prone position or the lateral position, depending on the surgeon's preference. You really have to remember you have to do parallel processing. So after these patients are flipped or turned on their side, that's when we do the block. We're immediately at the bedside. All of our local anesthetic is drawn up. We have a tegaderm on our transducer, and we're ready to go. So while they're doing the neuromonitoring setup, we can place the block so we don't slow the surgeons down. The most common reason for blocks not to be successful or for regional anesthesia programs to not get off the ground is that the anesthesia team does not do parallel processing, and they wait to do sequential processing, which slows the procedure down. We use a parasagittal approach, which is the most common approach for this block. We start our scan in the midline over the spinous processes. Then we move the transducer laterally until we see the transverse process, and we try to get the distal edge of the transverse process to optimize the placement of the local anesthetic. You can see the needle is an in-plane technique. It doesn't matter if you go cephalad to caudal or caudal to cephalad. In this photograph, the patient's head is at this end and their feet is at this end. It really depends on which side of the patient you're standing on. You don't switch sides for this block, and whether you're left-handed or right-handed. The end result is the same as long as you have the needle tip between the erector spinae muscle and the transverse process. You can see here in this picture, the needle coming in plane, hitting the transverse process, and the blue color here is representing the local anesthetic, dissecting the erector spinae muscle off the transverse process. For ultrasound imaging, the needle here is represented with an orange dotted line. The tip is on the transverse process. You can notice they are using a curvilinear probe because there is a deep level of penetration for the target. The transverse processes are bony structures. So you see the white hyperechoic bone, and the ultrasound beam is unable to penetrate the bones. You see what's called the black bony dropout below. Once you hit the bone, you cannot inject because the tip of the needle is against a hard structure. So you pull the needle back ever so slightly, ask your assistant to aspirate and inject. If you're in the right place, the local anesthetic will spread, dissect the muscle, and spread from a cephalad and caudal direction, giving you a multi-dermatomal spread. This is a pre-injection ultrasound image and a post-injection image in the thoracic spine area, in the TP4 and TP5 area. So you have your three muscle layers here, which are identified in color here, your trapezius, your rhomboid, and your erector spinae muscle. Your target would be here, again, deep to the erector spinae muscle. Post-injection, you'll see local anesthetic pooling between the erector spinae muscle and the transverse process. And you can see that here identified. Transverse process, local anesthetic, erector spinae, and more superficial muscles. So like every other plain block, this is a large volume block, and that's why you're always keeping local anesthetic toxicity in the back of your head. Having said that, I've been doing this for 25 years now. I've only seen one case of local anesthetic toxicity after an interscalene block, so it is still incredibly rare. We do this block for posterior cervical fusions, and that's where we do a decreased volume of 20 mLs per side of 0.25% Marcaine. More recently, we've started using Exparel for our posterior cervical fusions, and for those, we do 10 mLs of Exparel and 10 mLs of 0.25% Marcaine. We do not add Decadron if we're using Exparel. For spinal fusions, 4 levels or less, we up our volume to 30 mLs per side. And our admixture for those procedures are 10 mLs of Exparel and 20 mLs of 0.25% Marcaine. As our incisions and our operations get bigger, and spinal fusions for 5 levels or more, we up our volume to 40 mLs per side. Again, we only use 10 mLs of Exparel per side and up our 0.25% Marcaine to 30 mLs per side for a total volume of 60 mLs of 0.25% Marcaine, which is what we use for our tap blocks. So we're very comfortable with this volume of local anesthetic. In this picture on the right-hand side here, I did this block for this patient who had a 9-level fusion. For this case, I did use the 40 mLs per side. However, once we get to above 6 levels, I'll often split the levels and do 2 injections a side to really optimize my spread of local anesthetic. There is studies on cadavers that shows that you get 3 to 4 levels cranially and caudally with an injection site of 30 cc's of local anesthetic. But more recently, just published in Anesthesiology News by Jeff Gadsden of Duke, was a review of craniocaudal spread in lumbar ESP blocks and looking at where the spread goes based on anesthetic volume on cadavers. In this image on the right, the red represents 10 mLs of local anesthetic injected. The purple is 20 mLs, and the yellow is 30 mLs. And this is what they found. There was actually no evidence of epidural or paravertebral spread in these cadavers in the lumbar region. There was no anterior spread, so there is no interference with neuromonitoring. And that is a question your surgeons will ask you. And having done about 500 of these cases at St. Vincent's, there's never been an issue with neuromonitoring. So really a critical answer you need to be prepared to give your surgeons. As we expected, they got 4 levels of spread with 30 mLs of local anesthetic in the lumbar region. However, because of anatomic differences in the thoracic region, you can get up to 6 levels of spread with 30 mLs. And that's why we do reduce our volume when we inject a T1 for posterior cervical fusions to 20 mLs. So does it really work for spine cases? The answer is a resounding yes. And we have the data to show you. In 2020, as I mentioned, and we started our Erector spine, 2019, 2020, as we got our Erector spinae blocks off the ground for lumbar spinal fusions, we did a case series. My partners, Dr. Vlad Frank, Robert Suriani, and David Madurum and I got together, and we looked at 35 patients undergoing lumbar fusions for Erector spinae patients versus controls. We injected in the lower lumbar spine in the areas between L1 and L4, and we saw a significant decrease of morphine consumption, opioid consumption over the first 72 hours. That poster was actually accepted at the 74th PJA meeting last year, which unfortunately was held virtually, but we were really excited to get that off the ground. So we went on to do a retrospective case control study, and we looked at 41 patients, and we saw a significant decrease in opioid requirements at 24, 48, and 72 hours. And this was presented at our recent ASA meeting and actually got special recognition and was in a special session because the data was recognized as being so clinically significant. In this study, the blue are the control patients and the orange are the ESP patients. So you can see there is up to an 85% decrease in narcotic consumption over the course of 3 days. We also saw a mean time to first opioid ingestion was up higher in the ESP group, which you would expect because they had less pain. The take home from this study was that ESP blocks are an effective method for postoperative pain management for open fusions. We saw a decrease in opioid consumption up to 85%. So our goal this year is to do additional investigations to help determine the role for ESPs in terms of other measures, including rehab metrics, quality of recovery, and a cost-benefit analysis. This is a ultrasound video of an L4 ESP block I did. You can see it's a curvilinear probe. Here's the needle coming in. The tip touches the transverse process, and you can see the spread of the local anesthetic dissecting the erector spinae muscle off the transverse process. And the needle is here. Now, this can be a challenging block. This is at about a 45-degree angle. It's at a large depth, about 6 centimeters. That's why linear transducer would not be helpful. So sometimes you really can only see motion artifact and the spread of your local anesthetic. This really is less of an issue in the thoracic spine, but in the lumbar spine, especially when the patient's in the prone position where we do it in the operating room and they're in a lordotic position, often the visualization is not as good as you'd like it to be. Having said that, it's a very forgiving block. And if you see the local anesthetic spreading, it's going to work. So after we really hit home that we were having tremendous success with our lumbar ESP blocks, and we saw it from everybody, the recovery room nurses, the physical therapist, the physician's assistants, and the surgeons. They were asking us, well, why aren't you doing this for cervical spinal fusions? And the answer was because there was nothing published on it. However, at this point, we felt comfortable proceeding with a trial to see if the blocks would work. And did they work? Once again, the answer was a resounding yes. And if you ask our physical therapists and our physician's assistants who follow these patients postoperatively, they will tell you that posterior cervical fusions actually have significant more pain than lumbar fusions. And the profound difference they saw in these patients really astounded everyone on the team. So we did the first case series of ESPs for posterior cervical spine surgery patients that was also accepted at the IARS meeting in May of 2021. We saw the exact same results we saw in spine for lower spinal fusions, including excellent analgesia to multiple cervical levels due to the spread of local anesthetic. So we are confident that the combination of ESP blocks with our ERAS protocol really provided robust analgesia for these cases. One thing I wanted to mention was we talk about morphine equivalence, because even though our patients are on a protocol where they get dilaudid postoperatively, when they go home or they're getting ready to go home, different surgeons have different protocols as far as what opioid they wanted to use. So it would be challenging if we didn't compare it into a single type of equivalent to figure out what they were actually using. So just to give you an idea what 24 looks like, it essentially is the equivalent of 1.2 milligrams of IV dilaudid, or essentially 15 milligrams of PO oxy. So that's not a lot of opioid for the first 24 hours of patients having major spine surgery, especially in light of the fact our patients were getting dilaudid PCA for 2 days prior to this protocol. It's a huge change. We also track opioid consumption in the recovery room, and our goal for spine fusions is less than 30%. And over the last year, we've met that target consistently. This is one of the patients we had in the posterior cervical spine case series. This patient's in the prone position. Their head is here and they're in pins. I'm scanning the first thoracic vertebrae. You can see the needle is at a very acute angle when you get to this level in order to achieve the target. This is the ultrasound image we obtained with the 3 muscle layers, the trapezius, the rhomboid, and the erector spinae. There's the T1 transverse process. My needle's coming in from the right-hand side. The needle tip is right above the transverse process, and this block area is the local anesthetic. Now, I hadn't really thought of it before we got in the room, but of course the fluoro was there because the surgeons were going to do that as soon as I was done with the block. So I said to the radiology tech, why don't we take an X-ray? And here it was. The needle tip is right here on the first thoracic vertebrae. Here's the ultrasound video, the transverse process right here, the erector spinae muscle. The needle will be coming in from the right-hand side of the screen. Now, as you can see, I'm using a linear transducer. This is a much more superficial block, and a curvilinear transducer would not be helpful. The needle is going to go right here. The tip is there. You can see the local anesthetic spreading cephalad. Now, often once I have some hydrodissection with the local anesthetic, I'll readjust the needle to really optimize my spread of local anesthetic. In this case, I want it to go to the left-hand side of the screen. So I know, or I'm very confident this is going to be a successful block because you're seeing excellent spread of local anesthetic. So in summary, I'm very confident, and I can tell you with the utmost certainty that ESP blocks are safe, they're reliable, and they provide predictable results, of course, when they're done correctly. They're simple to perform, they're simple to teach. They provide excellent pain relief for posterior spine surgery. And we've seen with our protocol a decrease in narcotic consumption by 85%. And as a result of that, decrease in all the side effects associated with narcotics. At the end of the day, we have incredible patient satisfaction. Our surgeons are happy. Our hospital has gone on a media blitz talking about pain management, opioid reduction, and using it as a marketing tool for our surgeons to get patients from other hospitals to come have surgery at our hospital. We will be at the PGA next month to present our poster on quadratus lumborum blocks and PEC blocks for deep flaps. I really hope you'll stop by our booth. The integrated anesthesia booth will be there. The entire team, including myself, Dr. Vlad Frank, David Madorum, Robert Siriani will be there. We'd be happy to entertain any of your questions and talk about practice opportunities, obviously, with us. We offer a tremendous volume of regional anesthesia expertise, and it's a great team. So at that, I'd really love to entertain some questions. And certainly, again, feel free to email me at any time.
Thank you, Dr. Bowling. That was fantastic. And I just want to say the slide you're seeing right now, the recording of this presentation will be at this link, secure.sonosite.com/behind-the-scan webinar. And if there are any questions, we can take them now in the Q&A box or even the chat box. I actually had a question, Dr. Bowling. You mentioned that, oh, I turned my camera off. You mentioned how patient refusal is part of one of the barriers. How do you handle that? I'm just curious, what that story looks like.
I have to tell you, it's incredibly rare. I mean, maybe 1 or 2 a year with a patient that had some bad experience at some other hospital. Our team approach is the surgeons prep the patient before they come to the hospital that they are going to have a nerve block, and that is part of their surgical and perioperative care, and that it's a critical part of their pain management. Then when they get to the hospital, we have the fortune of having an excellent block nurse on our team that sees the patient even before anesthesiologist or a CRNA sees the patient. And she preps them. It's not really an option of, would you like a nerve block? This is part of our protocol. And now that we have this powerful data and we're published, when I go in the room or one of my teammates go in the room, I explain to them, you're going to have a nerve block. This is part of the protocol. And we've published a paper showing an 85% reduction in opioid consumption with this protocol. And patients don't refuse. Mm-hmm. So it's really in the presentation, Laura, how you talk to the patients. And when they understand it's part of the protocol and that the benefits are so profound, there's really no reason for them to refuse it.
Right. Absolutely. We just had a question pop up. Another question. Would you consider doing these in pre-op prone with sedation?
Yes. It's just not our practice pattern because for spine cases and the logistics of our operating room. However, on occasion, if we do have time for second or third cases of the day, and there is a gap in a room, we will do these blocks preoperatively. And with adequate sedation, the patients do just fine.
Great. Okay, we'll give a moment for any other questions. Okay, I'm not seeing anything else pop up. Thank you so much, Dr. Bowling, for your time and this excellent presentation. We will be posting the recording in just a few minutes, probably later today. And I love working with you, Dr. Bowling. Your expertise is wonderful. So thank you so much for taking the time.
Hey, thanks so much for inviting me. It's always a pleasure to work with you guys.
Thank you. Bye, everyone.
Bye-bye.